what qualities do we think, and I'd be interested in both of your perspectives on this, what qualities do you think clinicians can have or build upon in order to create this direction, this ability to synthesize the evidence, first person evidence, third person evidence, the totality of the evidence. And so we're not just talking about research. What qualities do you think that are essential, desirable, however you want to frame it really, that clinicians either have or could build on?
I'll jump in and then I'll pass it to Mick. But I think, one of the first and foremost things I think is having some intellectual humility, that you can go into a clinical scenario and not have the answers, because what patients bring to that in their context, as Mick alluded to, it might take 5-6 visits to really peel away and gain some alliance and that clinical friendship, to where people can share some things that start building a case of some of these dispositionalist mutual manifestation partners that might you can start unpacking with the person and, co-constructing that narrative. But if the clinician comes in at this kind of paternalistic, method of just kind of dictating the course of care to the patient without that intersubjective third space where there's, equal respect for the context that both people bring to the room. I think clinicians sometimes, hopefully this recognize the context that, this project helps clinicians recognize the context that they bring to, and some of the assumptions and philosophical foundations that they're operating under, that they can kind of put in check, and then just make sure that their interaction isn't them here and the patient here, that it's here. So you can develop that intersubjective and get the story and get as much of the context and shared narrative exposed, to where ideally you can make sense of a very complex phenomenon that brilliant people like Mick and others are still, working hard to get less wrong, I guess, about, is maybe the best way to put it. But I think that intellectual humility is one of the hugest things. And I think that was one thing just from my clinical experience, that, you kind of get this hero, and we talk in our courses, do you want to be Alfred or Batman? I think we get trained to be Batman in our careers, as far as like the hero comes in and has the answers, does the fix, does the treatment. But what we sometimes see, and what I've definitely seen is, and Rod Henderson's a friend and colleague who talks about, patients don't need more Batmans in their life. They need more Alfreds who can have that humility to just come alongside and construct that narrative where information can flow between both sides, and hopefully construct something that's constructive to move somebody towards something valuable to them. And I think that would be the big things. And a lot of what we talked about today is, this kind of biomedicalism, materialistic, empiricist view, which isn't necessarily wrong. As Mick said, it can kind of form part of the dispositionalist kind of mutual manifestation thoughts that we have with the patient, and they can be very helpful. But we also need to recognize that there's just a lot more going on in that human pain experience that the patient's context holds, that we need to develop a rapport and a relationship with, to hopefully get some of that information out and put it at equal footing as some of the things that we may have prioritized as the real evidence, the objective. And again, Bronnie Thompson's one person who's beat me up as far as saying we shouldn't even call it a subjective interview, because it makes it seem like it's not real. It's not the real information that we're getting out of people, yet we're seeing a lot of this information in science and studies of some of these biopsychosocial, psychosocial factors and such, can be very important mutual manifestation partners in how somebody's going to, maybe emerge a symptom and things like that. But I'm curious what your thoughts are on that, Mick, as far as, some of those factors and characteristics you think are necessary.
You picked my favorite word, Mark. So thank you for stealing that. Humility is key. It's key. And I hope that came out in my own humility, because so faults, now you've identified it for yourself, but my own humility of, I thought it was me. I thought I was failing. I thought I wasn't knowing enough. I wasn't thinking widely enough. It's that's a really important thing to retain for yourself. I think being open-minded, that sort of goes together with that. Being penetrative too. I think there's a time when you've got to know and pick your time to sort of, start to go down that gradient descent into more detail, into, also bringing up some arenas which people might not necessarily want to bring to you, But you can't do that until you've demonstrated humility, open-mindedness, caring. Kindness. People will recoil when you hear anyone in science or who claims to be a scientist to say kindness, and well, they can go wherever, because kindness is an important thing. We're human beings, and we're a gregarious creature, and we're learning that. Hey, some of the least gregarious people day to day I know have realized how gregarious they are as an animal during the time they've been locked away from other human beings. And I think that that's been a valuable thing with COVID anyway. So I think, I've been lucky enough to work with some of the world's leading people across many different fields, and they all share very similar qualities. They are open-minded, they demonstrate humility, they demonstrate the ability to be penetrative, to really focus in. I often say, the cleverest people I know could take you into a conversation where you have more knowledge than them, but they'll always ask you the one question you don't want anyone to ask you about your own field. They will get the question straight away. They penetrate to that single question that you don't want anyone to answer. And I think, that the best clinicians are like that. The Louis Giffords, the Dave Butlers, Lorimer Mosley's, Matt. They have that ability. They have that ability to operate at all sorts of different levels and to work at the appropriate level at the appropriate time. And that's not something you can just acquire straight away. It's not something that you can teach that easily, but you can take people through a reasoning framework. But again, when we say reasoning, we've all followed fairly similar backgrounds at different times, but still, within manual therapy, musculoskeletal physiotherapy, the hypothetico-deductive reasoning model that Matt alluded to earlier still sort of dominates in some way. But I would say that, I do want to give a name check to Ian Edwards, who obviously was part of the work with Mark Jones, the original work around clinical reasoning, hypothetico-deductive reasoning. I've never met anyone who, in my career, who quite embodies actually everything about what they write and about what they say in the way that they live their life, as Ian. And I think, having spent some time in his company was I feel hugely privileged for that. And I've spent the time in the company of a lot of people who I feel hugely privileged to be in. But I think he would demonstrate everything you need to be a great clinician. He knows his science, he knows his theory, he knows about human being. He chooses to live his life in a life world where other people's life worlds are just as important as his own, and he constructs his own life world with that as a consideration, as a first way of thinking. And that starts to break down some models, because people get that very quickly. They start to see that you are genuinely as bothered about what they think and how they feel as you are talented enough to have an impression about what they should feel and think when they present with a particular condition or a particular healthcare consideration. And I say it that way, and hopefully that comes across in the right way, because that's important too. It's important that people see that you do have the necessary skills to think like they expect you to think as a professional who identifies within the profession of your choice.
Yeah. I think you're absolutely bang on with it, with everything. But in particular, Ian Edwards, I'd love to meet him. I think his work is fantastic, and he really brings the ethical dimension to clinical reasoning, like I think nobody else has. I don't think within physiotherapy. And it's often the forgotten area of clinical reasoning. We tend to think about pattern recognition, we tend to think about hypothetico-deductive reasoning, but very rarely, and he's published quite widely on it, on the ethical considerations. And I think that idea of of putting the other person first and foremost, the ethical context, and everything that comes with the clinical encounter. I think that is, fundamental. So those qualities of kindness, curiosity, epistemic humility, intellectual humility, social and psychological flexibility. So the ability to be able to read a room. You see these people who have that ability. They can walk in a room and just kind of work out, bang, like the atmosphere, the kind of conversation, they fit in, they kind of understand the mood and where everything is. And the psychological flexibility to recognize that, in some situations I might need to be, in terms of explanation, let's say, for example, of causal explanation, a person wants to know what's going on. If you pick up on a person's history, by that I mean perhaps the type of work that they do, which may lend themselves toward thinking in a particular way, you may frame your explanation in a way that suits their perspective. So for example, an engineer, as much as we may criticize biomechanics, if that person doesn't perhaps get some kind of understanding which frames his understanding of the world, then how is he going to have any foothold in order to develop further? So I think that psychological and social flexibility is a great quality. It brings all of these causal factors and it makes it real. So, I don't know what you guys think of those qualities.
I want to follow that up by saying, how difficult is your job? What we, the three of us, have outlined there is to do this well, really, really well. It's really difficult. It asks a lot of the person. It asks a lot of the person who is taking up the responsibility of providing care. And I use the word care in its widest sense. We're actually outlining a perfect, almost sickly human being here. I'm proud that I don't have all those traits. But all joking aside, that's a real ask for anyone, isn't it? It's a real ask. We're setting up people to be inadequate against some of those things that we've just outlined. And that's a real tough thing. When you see it, when you see it, it's effortless. That's the thing. If I go back to Ian Edwards, I mean, I could say very similar things about Louis Gifford. I could definitely say things like that about Andy Clark. My wife, Kath, I gave a lecture up at Edinburgh to some very, very highfalutin philosophers, lovely people. And Kath came along, who a very bright individual, but doesn't talk any other language of philosophers. And Andy almost sat and interpreted a conversation, between lay language and quite heavy duty philosophy in a way that I'm just not qualified to do. Yeah, he was integral to the conversation. He was in and out of that conversation. He empowered Kath to join in and add, hugely important things to the conversation, because the conversation was about healthcare and she is a physical therapist too. You just see moments like that where you sit back and go, wow. I hope I've got some of that talent in my own field, but I'm not confident I have. I think it was a hugely powerful thing to observe. And I would say that you could train him very quickly to be able to do the sort of things we're talking about. Someone like Pat Wall would be the same type of human being. He was a clinician anyway. But these are incredibly impressive human beings, and we're sort of asking for that level of impressiveness for people day in, day out. And that's why I say, how difficult's your job? How difficult's your job to try and be all of those things all of the time? But I think patients and other people, and let's say that's what we're talking about. We're talking about people, other human beings who we label patients, clients, whatever. They're forgiving. They're immensely forgiving that you're not perfect, and they don't expect you to be perfect. they're accepting of a lack of perfection most of the time, not always, you know, but yeah, the huge percentage of the time. And I think that's another quality to have, is to be comfortable enough and self-assured enough, self-confident enough to say, okay, I'm allowed not to be all of those things all of the time in every situation, because I can't be, you know. And actually people will demonstrate to you all the time, you're allowed to be non-perfect. And I think that's one of the, I still feel, if you said to me, do I miss being a clinician day in, day out, I miss that sense of human beings who come putting themselves into your hands, both metaphorically and literally in many cases. You know, they come and they offer that level of trust and level of personal communication with you that is a huge privilege, you know, and not one, you know, back on theme, hopefully, not one that you can get very easily in science, not one I think you can get very easily in philosophy. Yeah, but I think, how do we work people towards that, I think, is actually giving them a framework such as dispositionalism, which actually naturally takes people on that journey. If you don't, it's not about blind faith or believing in anything. If you work with it, if you work hard at it, you know, because let's face it, you can be falsely humble or have all the humility in the world in real terms, but those really humble people with huge amounts of humility have worked really hard as well. Behind that is this incredibly powerful work ethic to know as much as they can, which allows them to know what they don't know and be confident in what they know and confident in what they don't know. You know, I hope I'm not waffling on. I think it's sort of, you know, it's yeah. I mean, that's for me is the essence, and having a framework that is durable, realistic, doesn't offer false promise, doesn't. When I say that, I mean about unnecessary expectations of being able to find causative factors which follow that very linear path that Matt was explaining, because that isn't biology, by the way. You know, if we said something that is unidirectional, there ain't no biology. Homeostasis, allostasis, they're not unidirectional things. You know, the human body is not about unidirectionality. You know, I made the case for the weekend about your nociceptive system. You're classically taught your nociceptive system starts with a primary afferent fiber, goes to a second order neuron, goes to a third order neuron, right? And that's where it begins. And you know, and there are some books that would say that's your afferent system for pain, okay, or that's your nociceptive system. But and then they would say, oh, you also do have this other system involved in pain, by the way, you know, your effector system, the output systems. But you know, they come in because they're sort of secondary to this sort of other stuff. You know, they only respond to that other stuff. And just there never has been any biological plausibility to that, which is what fascinates me. Never ever has there been anything biological that plausibly supports that. You know, and that's, again, perhaps how this thing works is I'm confident that I can say that, and I could back that up to a neuroscientist, the best pain neuroscientists in the world, the best clinicians I know in the world, and perhaps having, you know, worked in all these different arenas allows you that confidence to be able to take on those difficult conversations. But in all of those different arenas, I've never had as complicated interactions as I ever had as I've had in the clinic. They are the most complex interactions you can have. They occur in the clinic. how difficult's your job?
Mm. And so you speak to self-kindness and compassion as well.
Yeah, I mean, look, Matt, I would love to say to both of you, and I don't know this, but I'd love to say you've never been near burnout. I'd love to be able to say that to you. I don't know, and I wouldn't be very confident to say that about either of you knowing who you are, because one of the dangers for all people who are committed to what they do and committed on a really deep and personal level is there are times in your career where you'll get close to burnout. I've personally been there. I expect both of you have, but I also, getting to know you both pretty well, would know you're probably more sensible than me to spot it and then to pull away from it, But I would urge people to be wary of that too. I think one of the essential things for being a good clinician is to take care of yourself and to like yourself where you can, and if you find it a struggle in your day-to-day life, just know that being a physical therapist and trying your best at doing it well is an incredible undertaking in life. It's not only a privilege, but it's something you should feel good about every day, in my mind. You really should. It's a really decent thing to do. I don't want to bring a Buddhist philosophy in, but if you live a noble life in Buddhism, doing things that benefits other people and have an aim of doing that, even if you don't always achieve it, is a really noble thing to do in so many different philosophical sort of spheres and different areas of thinking. And I think I look around at physical therapists and see them doing that all the time, but it isn't easy.
No. And I think we've on this journey that we've just taken today, we've kind of cast a large net, haven't we? We've discussed notions of evidence across research, practice, the person, first person, third person perspectives. We've looked at different philosophies of practice. We've also covered qualities of a clinician. Do you think there's much more you would like Des to talk about?
Honestly, it's been a privilege just to kind of hang out and participate in this conversation. It's been, hugely valuable to me, and I hope for the folks that are watching it now are having some of the same value. I think, the complexity of evidence is there's a lot of complexity. As Mick said, how hard is your job? It is hard, and human beings are hard, and relationships with human beings and trying to co-construct narratives that move somebody towards valued living and valued goals is not easy stuff. But I think hopefully this project has pointed out the fact that we can't just rely on third person knowledge to change a first person experience. And that's where grasping onto some of these philosophical constructs as dispositionalism and some of these communication sociology and looking outside of just this biomedical, which has given us some valuable knowledge to bring into the narrative and the context of that interaction, but has been fallen woefully short of explaining, some of the complexities of it. So hopefully we recognize that complexity, and as Matt and Mick have nicely pointed out, have some self-compassion that there are times where we aren't going to know it all. We're not going to have the solution, and we can't put that pressure on ourselves, because I can definitely relate to what Mick said about burnout, when you feel like you just aren't getting the answers and you're pursuing them so crazily day by day, yet still feeling like you're running into the same walls. But maybe there's just so much more to it, as far as maybe the answer. You don't have to come up with that one answer. You can come up with a plan and something to move your patient forward. But the evidence that can inform that plan, again, needs to be shared and brought in from multiple sources, not maybe the ones that we've traditionally formatted. Sure, our randomized controlled trials and systematic reviews can give us valuable data, but in the end, it has to fit the narrative of the person in front of you, which hopefully we've touched upon that today. I'm curious, I want to respect both of your time, because I really appreciate the time you spent with us today. Mick, you've really already laid it out beautifully as far as your last statement, but any kind of future, if you were to kind of nudge folks as far as how do they kind of move towards maybe this way of practicing, any tips or desired readings or things that might help people see kind of things a little bit more broadly than maybe how their education and even post-professional education has kind of moved them. And then we'll just wrap it up.
Yeah, I think you mentioned the word there, reading. I think, you know, it's something that yeah, I'm on record again as saying that I read for 2 hours a day, which is absolutely true. You know, every day of my life, no matter, you know, what else is going on, I try to find 2 hours of my space to read. But you know, and reading's a discipline, and it's difficult, and I appreciate people live different lives, and I've prioritized it in my own life in a way that other people around me are fortunate. You know, I'm fortunate enough; they give me that space and they respect that for me. I think the other thing is that reaching out to people from different disciplines, which I know the three of us have been lucky enough to do. But again, if I went on that journey, you know, I sort of outlined at the beginning, you know, hopefully I've been prepared to go outside of the traditional sources to get information, to have the conversations with people. You know, I'm hugely indebted to all those people who said yes for giving me some of their time. But I'm also shocked at how readily they do that. You know, people who you've had on here, Arnie, with your experience, Matt, you know, Stephen Mumford, you know, these are people who had no reason to engage. Probably Roger was the reason, but, you know, but they've got no real reason to engage. They, in the first place, I think physical therapists would say they've got nothing to benefit from us by giving us their time. But I know when you talk to those people, they say, wow, you know, you're bringing the real world to us. You're bringing the sort of situations and the sort of experiences we can't get ourselves very easily. And I know that's certainly the case for someone like Andy Clark. You're bringing something that doesn't normally come through my door with me, which is human contact at the sort of level we operate. So I'd urge people to be brave enough to write that email. Oh, I've always wanted to write to X. I've always wanted to get in touch with Y. Do it. Do it. You know, if they don't get back to you, you probably learn a little bit about them. You know, although they may be busy, and everyone in this world is very busy, but reach out to people. You know, don't constrain yourself to I'm just a physical therapist, I'm just a chiropractor, I'm just an osteopath. No, you're not. You're a living, breathing clinical scientist, clinical philosopher. You know, most people who get a doctorate have a PhD. It's a doctor of philosophy. It's yeah, we're all philosophers at different levels. You know, and I think you know, engage with people from different backgrounds and different professions. I would urge you to do that. If you've any hope to achieve becoming the type of clinician that we're advocating here.
Yeah. Yeah, and I would say that what's really interesting is that there's a common theme between us three in the context of our education is postgraduate education within the profession actually provides a solid foundation for future development. So, you know, there's lots of negativity that I see at times where people say, well, you don't need to do a master's, or well, that's true, of course, but they're critical of externally validated sources of education. But equally, they then say and smack you over the head with non-externally validated evidence, which I find is quite an interesting paradox. But what I'm really appealing to is the idea that you can start building a foundation of practice that provides that confidence, that provides that sense of professional foundation that you feel comfortable with within your profession. But I absolutely agree with what Mick says. So for the MSc, for me, when I did my master's, which again, I'm a member of the MACP, that again, you know, does come under criticism, but actually it's there is this similarity. I can't get over how close our stories are in some respects, but what that does do is it creates that ability to be somewhat self-critical in a purposeful and fruitful way, and then you move on from there to open yourself up to exactly what Mick is talking about, above and beyond your profession. So I'd encourage that kind of fruitful direction towards, not just in the States, I think it's different, but here there are higher education institutes which are, really well, externally validated. They have rigorous methods of external validation within themselves. And so I'd encourage that kind of journey, because if you feel uncomfortable where you are in your profession, how can you look to other professions and other fields? It's very much more challenging. You can get lost in your way. So I'd recommend that kind of movement.
No, it's well put by you both. I think, the only thing I might add is just, having a critical thinking mind, and one that, you develop a metacognitive process as far as thinking about your thinking, because just, again, where I've really, the most breakthrough is I didn't realize a lot of the implicit things that I operated under. And this project and a lot of the talk that Mick and Matt had today is just to recognize where our thinking comes from. And that gets into some deep philosophical constructs, but it's been founded often by a method of education that, we've kind of pointed out maybe some of its, limitations, not completely, of course, by any means, not useful, but just limited in the understanding of what we know, especially when we get into, dispositionalism and causation and different things, where that linear, maybe biomedical way of looking at pain has, maybe not served us as well. It's definitely given us some good information, but and good things to go off of, but it hasn't maybe given us the breadth of the complexity of what we're dealing with people. So we could probably talk for longer over some beverages, I'm sure, but I want to, again, respect your time. But first, I want to thank you both for so generously offering your time today. Again, I had a huge enjoyment and value from just listening to you both. I felt like I could just sit back and hang out and listen. But occasionally had to throw at least what I attempted at an intelligent comment in from time to time. But thank you both for your time, and thank you both again for your continuing contributions to, greedily me as far as my development. You two have been two very impactful figures as far as my development as a clinician, but I know I speak for a lot of clinicians and people out there that you've had a huge impact on their growth and development as well. So thank you both again for your time today.
Thanks, Mark, for that. And pleasure always to work with you, Matt. And obviously, same comment to you, Mark. Enjoyed both of our interactions. So thank you for all you guys are doing as well.
Yeah,
appreciate it.
I'm really grateful for the time as well.